Dr. Rohit Mody is all the way from Bathinda. If you want, if you really want to know one person from India who has represented India globally, every corner of the globe, starting from Israel to France to US, and many journals of international repute, it is Rohit Mody. And he's doing a tremendous job from Bathinda, and his produce are of excellence and high quality of PCI, complex PCI. And the depth of knowledge really impressed me. His presence is felt not only in journal, by his commentary in our social medias, interactions with the juniors, and helping juniors to know the newest technology, the newer philosophy of treating human beings with Midas touch. Over to you, Rohit.
Thank you very much, sir, for my kind introduction and elaborate introduction. I am really honored to have introduction like that. So I think the first talk is I think a talk which is virtual. I'll be going with my talk first. That is how to treat calcified lesions, especially focusing on left main to LED. Why impact of coronary calcification? Because we all know that calcium is a marker or extent of coronary atherosclerosis, and calcification results in suboptimal stent results due to impaired stent delivery, due to decreased stent expansion, due to malapposition, stent asymmetry, and there can be complications like dissection and perforations. So the prevalence, as you see, mild calcium is more common than moderate and severe. Again, as I said, the clinical outcomes are poorer when the calcium is present. We know calcium is a finally enemy of the interventions, and severity of calcified lesion limit our stent expansion. So there is a discrepancy between IVUS and OCT as we see these with angiographic in measuring the calcium. So while doing a patient of calcified lesions, you should always be prepared for the worst situation. There should be warning to the patients. There should be a strong guiding catheter. You can use a guide extension catheter if needed, and preparation with a atherectomy device or IVL device these days. So these are the guiding catheters which are used: telescope, guide liner, guidezilla, guide extension. This is a patient being done LED left main with a help of a guide extension catheter. You can see the IVUS. The principle of treating the calcified lesion is do not stent on poorly prepared calcified lesions. So my dictum is lesion preparation, and lesion preparation. So this is a 65 years old male. You can see there was a superficial calcium that could be tackled with a compliant and a cutting balloon. So the approach to the calcified lesions can be a high pressure balloon, an angiosculpt or cutting balloon, a rotational or orbital atherectomy, intravascular lithotripsy, and a laser atherectomy. So this is a IVUS post balloon. You can see the fracturing, diffuse multiple heavy. This was a heavy calcified nodule that was treated with a balloon. Then imaging for the calcified lesions, you must ascertain that what is the quantity of the calcium. We label it as mild to moderate, mild calcification, or moderate to severe calcification. So these are the scoring system used in IVUS for the calcium scoring. And then after preparation, you have to check for the calcium breakage. You can see in the IVUS as well as OCT the fractures produced by the various treatments. Check the calcium breakage. There can be, think of like this patient had perforation while putting a stent because of the calcified lesion. Perfection, because you need not go to the perfection, because perfection is sometimes enemy of the good. And while performing a perfect procedure in a calcified lesion, we may get complications. So the practical approach would be always be prepared for the worst situation. Intracoronary imaging is helpful to plan the strategy, guide the procedure, and finalize the result. Prepare the lesion before stenting with every effort you can. Please take care of post-stent optimization. Safety is first. Do not oversize too much. So these are the ways we detect calcium, not only the imaging, but coronary CT and angiography, IVUS, OCT. These are the representative imaging using dual sensor images. Post rotablator, you can see post high pressure fractures, and these are the fracture plaque modification of CLA by scoring balloon. The eccentric heavy thick calcium you can see in a LED left vein lesion. OCT findings, even with POBA and stenting, the final angiography. A word of caution while using LCX ostial lesion, two types of coronary perforations by rota you can see in these patients while doing the atherectomy. OS is high speed orbital atherectomy, is a modality, high speed modality. If we can pull back, this is the OCT finding, low and high speed OS. Then a word about calcified nodule. You can see the type of nodules like eruptive and nodular. These are the two clinically relevant calcified nodules. This is a patient done with a rota in a calcified lesion. This is a distribution, and the calcified nodules are specifically located at the torsional stress. This is generally at the region of dense calcium. They are located at the sites of dense calcium. They occur at the sites of torsional stress and severe calcium. This is the pathogenesis of eruptive calcified nodule. How the lipid plaque forms a calcified sheet and fractures and hemorrhage, and then a eruptive calcified nodule. Erupted calcified nodule, then in an unstable patient of ACS, then a pathogenesis of protruding nodule. Again, the calcific progression occurs and forms on a lipidic plaque with a sheet producing a protruding nodule, and then this protruding nodule is a clinical entity. So this is a protruding calcified nodule. The problem cannot be differentiated angiographically, cannot be distinguished by intravascular imaging. This is the protruding calcified nodule, which is deformable. That is called marble in pillow, or it can be a marble in rock. When we try to inflate such nodules, they will behave like a rock and not move. And why can't ultravascular imaging method help? You can see the both the IVUS and OCT identifying the nodules. So how can we differentiate? You go with a balloon response. If there is eruptive or protruding deformable nodule, you can inflate it with the balloon. But if you get a dumbbell on balloon, this is a protruding non-deformable type of a calcified nodule. So the principles of treatment, we can treat with a balloon, semi-compliant, non-compliant. This is the pattern of expansions. When we put a stent on these calcified nodules, it can give a concentric expansion in a eruptive calcified nodule, or a deformed nodular calcification. And an eccentric type of expansion has to be accepted in a non-deformed nodular calcification. This is a flow chart of calcified nodule. I don't go into detail, but the principle of the therapy is again to see whether it is a mild calcium, moderate calcium, or a severe calcium. Then we can apply our various techniques depending upon the severity of the calcium. So this is the calcified nodules. The principle of therapy, calcium-specific therapy, should be selected according to the individual lesion characteristic. Rotational atherectomy can be used as an ablative therapy. It can be a first choice for critical lesion for volume reduction. This is the rotational atherectomy. We must take care of the wire bias. Then orbital atherectomy, where the wire bias is not a problem. It is a less dependent technique on wire bias, the orbital atherectomy. So this is a patient where both rotational and orbital atherectomy were used, and finally the probably orbital atherectomy was successful. This is a deformed nodular calcium base. I will late how can be used for lesions in calcified nodules. There are less restriction, and size to vessel should be optimal. There is no effect on calcium volume. It helps by breaking the calcium. And the calcium nodules are associated with various adverse outcomes. So I can take time if there is time. I can take some time in explaining this. How we approach the modification. This was a modification given by me in Journal of American of Cardiology, which was published. So I'll slightly emphasize some time on this slide. Uh, this we once we have to deal with the calcium, we do imaging with either OCT or IVUS to assess the calcium. First, we see whether it is deep. First, we assess the whether it is mild, moderate, or severe. Then we can see whether it is deep, whether it is superficial, whether it is nodular or uncrossable lesion. So if it's a deep calcium, I think the balloons in that case, like scoring and cutting balloons, will not be not be much effective. So in these patients, I think IVL will be the ideal choice. I've kept the IVL first in this choice. The second choice can be orbital or rotational atherectomy. And if it is superficial, superficial, any of the modality like orbital or rotational atherectomy can be quite effective, as well as IVL is effective. And for nodular, I have discussed already in detail. We can use orbital and rotational atherectomy in these patients. IVL is an important investigational tool and has been found in number of the patients to be very effective tool in this subset of patients also. The important subsets like severely calcified lesions with a clot. Here, the two modalities of laser and IVL. There will be number of the choice. The laser would be the best choice because when there is a clot, we use laser naturally to dissipate the laser. Laser is the best modality for the clot, and even for the calcium, this is a good combination with calcium and clot. And IVL, the new modality, has a neutral effect on the clot and can be used in situations like acute MI, where rotational atherectomy has been used. I don't say it has not been used, but it is always fraught with more complications in this clinical scenario. Similarly, for the underdeployed stent and which are due to calcification or ISR, where we find there's a calcified plaque, we can treat these patients again with IVL. I will keep as the first choice, and the laser the second choice. And we see the expansion on OCT and IVUS, or we can see the NC balloon expansion and then deploy the DES. So this is in nutshell, which I have described, that we must look for the treatment, first of all, the quantitate the calcium and then decide our treatment. So these are the various modification methods which are used in different calcium, like deep calcium, IVL, Ivagam 3+. For superficial calcium, IVL is 3+, and as such, the rotational atherectomy and orbital atherectomy is 3+. For nodular calcium, OA is 3+, and still the IVL is coming up with 2+. Still, the indications are to be explored. So similarly, in ISR and clot, the IVL and laser are the treatment of the choice. So to conclude, lesion modification by atherectomy would be recommended if imaging devices could be passes through the tight could help us to pass through the tight lesion with severe calcification. Confirmation of the plate fracture by imaging modalities should be done. Calcium plate fracture can be obtained after high pressure ballooning following step by step calcium ablation. by atherectomy or by IVL system. Calcified nodule demonstrated poor prognosis compared to non-calcified nodule even after ablation under the guidance of the intracoronary imaging. Thank you very much.
Thank you. Thank you, Rohit. Please take a seat. We'll take a question later on.